So welcome back. And we continue with the next case study, this time on digital and social care and domiciliary care. And it's my pleasure to introduce Ryan, who is the Chief People Officer and Policy Officer at Connected Health. Ryan, over to you.
That's great, guys. Thanks very much, Brendan. Just trying to double check here where the presentation is coming up. I don't see the forwards. Okay, you might have to help me just with the forward piece, but that's okay if you don't mind. Hi, everybody. I'm delighted. Yes, if you can move them for me, that would be great. As Brendan says, Ryan Williams. I'm a co-founder and director with the Connected Health Group. Quick bit of background on me. I'm a field lawyer, you'd be pleased to hear. So they do exist on the planet, which is a very, very positive thing, I think. Connected Health, very interesting business. We bought a very small home care provider about 12 years ago in Northern Ireland, employing about 47 people. Today we employ about 1,800. We do about 40,000 hours of home care per week across the whole parameters of kind of physical home care right up into augmented technology with physical care and indeed virtual care and a range of other things that we'll get into. That equates to around 6 million physical care visits per year, just to give you a flavour for what that looks like. And if you look at home care or domiciliary care, as some people prefer to call it, it's a really interesting part of social care. So we do 6 million physical touch points with clients every single year, and we collect virtually zero data. At least that's the way the industry was and has been for the last 30 or 40 years. But actually, when we do the analysis in terms of home care, we touch our clients about 40 times more often than any other part of the health and social care system. So in terms of its integral value to what we might do in terms of helping people to live well longer, we think home care is something that just needs to be developed and rolled out and become a much more integrated part of the overall system and not the poor cousin that it often appears to be today, particularly in the UK and Ireland. So I've been asked today to look at kind of the digitization piece and how we see that within health, but particularly social care, and do some kind of almost a bit of an analogy in terms of why digitization is so difficult in the likes of social care and indeed home care. If we just stick with the previous slide for a moment or two, if you don't mind, guys, thank you. Thank you so much. So if we look at the broader health and social care system in tandem with the likes of banks, banks are a good comparator in some respects. Some of our banks are huge global behemoths, and there is no doubt that banks have significant problems with digitization. But most would say that the banking and finance industry have done it better than healthcare in the main. And it's probably down to a few simple things, particularly if you look at the new banks. So if you look at the banks, the likes of the Revoluts, the likes of the Monzos in the UK, who've come into the market, their digitization is second to none. The customer experience is just superb, but they're starting with a blank sheet. If you look at the institutional banks, the likes of the Barclays and banks like that, they've struggled with digitization as well. However, what they have done, despite the same amount of regulation and challenges they have within that, they still see the customer as someone to please. And what happens within health and social care, I believe, is that we have this kind of fix me now type strategy, survive versus thrive. So you've had a car accident, yes, we can respond to that. But what we're really good at doing in health and social care right now, right across the world, is saving people from immediate death, but not helping them make their way towards death in a really healthy and a way which adds value to those final years, those final kind of couple of decades. So we're really, really bad at dying well, essentially. And I think that's something which is about how do we focus on the customer to make those outcomes better, essentially. We've also got to think about the energy of commissioners in this and procurement empathy. So what we find within the UK and Ireland right now is a significant amount of a significant lack of knowledge around what we're actually trying to commission. So if you look at the number of people who are in a procurement capacity within the system right now, who are actually ever had any experience with clients or patients or any social care experience, there's essentially none or very, very few. And if you're not educating the commissioning process and making the commissioning process as technology enabled and as digital as we possibly can, understand how that digitization and innovation can impact on really sound commissioning within a social care sphere, how could we possibly hope to get better outcomes? So what we need more of is the seeing as believing type experiences outside commissioning processes. where people who are involved in procurement come and see what digitization actually can do in a real world context and commission and procure on that particular basis. That's what banks do. That's what other industries do. They try before you buy, essentially, in a real world context to improve that customer outcome. But putting the patient and the client at the center is critical there. We've also got an issue in terms of frontline staff. So we look at the NHS today, we see staff who are threadbare in terms of the amount of responsibility and just the amount of things they're having to squeeze into their working day to keep the system moving. Yeah, and that energy of frontline staff to say, look, here's a new digital product we would like you to roll out with us over the next number of weeks and months and years. Here's some additional training you want to do. The appetite for that is often insignificant. It's just not there. There isn't enough energy often to throw their arms around new digitization. And as a consequence, if people don't embrace that on the front line, the technology will fail, because technology on its own, as we all know, is not a solution in itself. The other key challenge we have in the UK in particular, we do a significant number of hours for the NHS as an outsourced provider within home care. The NHS is just an oil tanker. Sometimes we don't really comprehend just how big an employer it actually is. It's the 6th largest employer in the world. Two steps below, I believe, the Chinese Liberation Army, so a significant number of people. 1 in 20 people in the UK rely on the NHS for their income, for their family income. That is just bananas in terms of its size and scale. It takes £3 million per minute to run. That's the kind of scale of this 24/7, £3 million per minute to run. So you're always going to really struggle to ingrain and digitize anything in something of this size and scale. And if you look at some of the failed kind of digital and technology rollouts within the NHS, they are just not good at doing technology. And lots of this comes down to just its size and scale. It's also really difficult to entrench innovation and digitization in a ship that's sinking in real time. So there's so many other problems in terms of staffing, in particular, talent coming into the NHS to provide the full range of health and social care. It's really difficult to entrench innovation and to get people to think differently within the NHS and the various providers within that infrastructure to think about, well, how can we do this better? And that's a real challenge. And we also then have to think about the expertise within the health and social care system, particularly in the UK and Ireland, to provide the technical leadership. So if you look at the public sector in terms of the types of roles that we create, we have a huge competency-based model. So we look for people with really good communication skills and leadership skills. But actually the technical leadership to make some of this digitization stick is just not there, because it's in other industries and it's been used up in big tech companies and companies that can pay a little bit better, that don't have the stress and strains and the pressures of a frontline service in the same way that health and social care does. Those sort of things are really, really difficult, but there's a dearth of technical and innovative expertise within the NHS and the other providers within the system right now. Maybe we could move on to the next slide. However, all that sounds quite negative. I'm not a negative guy, as you could probably pick up. All is not lost. I think what we've become pretty good at across the UK and Ireland is actually looking at innovation in bite-sized chunks. So where will digitization add the most bang for buck, essentially? And in doing those things, we've become really, really good at doing pilots. Really, really bad at building airports, but really, really good at doing pilots. What we're not then good is taking those pilots and diffusing that best practice out wider and seeing where the bigger wins can actually be had. That's where it gets more complex. But actually, if you look at some of the pilots and innovations that ourselves in Connected Health and parts of the NHS have done over the last number of years, some of the data around this and the data analytics is the way we're going to win here, because we can prove and test and prove again in ways which really resonate with commissioners, with stakeholders in the system and things with that. The other thing we need to get back to in terms of entrenching this innovation and the opportunity of digitization is to really put the client back at the start of the process again and work outwards. We continually get involved in these chats which have little or nothing. The client's kind of sitting way over here and we're doing things that are way over here because that's the process that we're being taught to follow. If you accept within the public sector that the public sector is designed to slow things down, right? If you accept that premise, because we're using taxpayers' money and we want to make sure money is spent in all the right places, that is the counter of what innovation actually is, and fast moving, break things quickly to find out and test what actually works. But not all of that is possible within the entity that is the thing, the NHS and the various bodies that commission within that. But if we get back to starting with the client, we are convinced that the outcomes will be better, and making sure that that digitization process and that mapping process goes outward from the client and not the other way around. That's critically important. Pop on to the next slide. So this is kind of a connected health, a quick visual on what we think home care should be about in terms of the wider health and social care system. And if you think about the line along the bottom about as somebody's basically getting older, these are the types of services within the care curve that we think are most appropriate. And then the complexity of service obviously goes up the other axis there in terms of the types of services. Usually the cost of services, so usually the cost is going up a bit there as well. Not always the case, but it gives you an idea of what that looks like. But if you look at a simple home care service, just a simple physical home care service, for 1 month of home care, you get 1 week in a residential bed and you get 1 night in hospital, right? If we ask clients time and time again, where do you want to be? It's always at home. Always at home. The number of people who never want to go to residential or nursing care certainly do not want to be in the acute sector. So how do we help people stay in the home for longer, where the outcomes we know are much better across a whole series of data points? So but we need to reconfigure what home care means to people. And for us, home care is simply this: any form of care, right? Whether that is social care, whether it's medical, whether it's clinical, whether it's nursing, that can be delivered in the home. And if you think about the care curve, one of the things we have at the moment is, particularly in NI and the Republic of Ireland, is really short visits. It might be 15 minutes a day, right? Where somebody goes into a home environment and says, Mary, how are you feeling today? Yeah, take your medication in front of me. Signs a book physically. Yes, we still have that in lamb's blood. We still write that into the little care plan every day, as opposed to a digitization process, which we also run in parallel as a provider of 40,000 hours, but you get the drift. But the idea of virtual wellness and virtual care and check-ins and medication prompts done virtually with a virtual carer who has a relationship with that particular client, who do not need physical care. They don't need someone physically to go into a house and say, please take your medication, or how are you feeling today? Because lots of occasions, the older person doesn't need that yet. If we put that physical presence into the home too early, the dependence that's built up in that is actually counterproductive to good health outcomes. Okay, so there might be a scenario where we can look at a virtual wellness and a virtual check-in type service, right, which removes the need for that physical care for another 3, 4, 5, 6, 7 years. That is a good thing to do. That service doesn't currently exist to any great extent within the NHS today as we speak. There are pockets of it. There are pilots that are successful. We've done some ourselves, but it's a really simple thing to do, and it's a really simple piece of digitization and innovation that's tried and tested. Okay. If we then look at kind of the virtual and a wearable type scenario, and then up into a kind of physical home care with a wearable virtual mix. So within Connected Health, we have a living lab. We trial and test third-party technology because we're not a technology company, right? We're pretty poor at that. We're not going to build software teams and product development teams, because that's not what we're good at. We're good at care. We're good at understanding about how our clients think and operate and their functional kind of needs. Yeah, but we're not a technology partner. What we are damn good at is testing third-party technology and innovation and deciding what technology works for us. So you look at the wearable market in the US right now, across the world right now, you've got thousands, tens of thousands of various types of wearable devices. We've selected one little device. It's another startup in Ireland called Paxana. Paxana does a number of things really well for our particular clients. You might say, well, why not give everybody an Apple Watch? Why not give everybody a Garmin? Paxana does a few things really well. First of all, it needs charged once a year. Charging a big issue. For people who are getting older, you might forget to charge something, right? But once a year is really good. This wearable is really discreet. You can wear it in the shower. It's waterproof. It looks like a slightly slimmer version of a Fitbit. It's really discreet, because guess what? Older people don't necessarily want you to know that they have a wearable which is helping them with their health, etc. Because there's a dignity aspect, there's a pride aspect, simple as that. In terms of the data points, what does it tell us? How long an older person slept, how much they've moved around the house, geofences on mild dementia, moderate dementia cases if they leave the house, so we can manage that as well. It is fall detection. That's all I want. That's all I want in terms of this simple data point, and that tells us a huge amount about how that older person is performing within the home environment, how escalation might be required for various things, how they might need an OT, for example, how they might need referred to their primary care. But that data tells us a lot. If we then look up into kind of broader and more clinical and nursing aspects around this, we can look at nurse-led or nurse oversight type care with clinical grade monitoring. So lots of occasions now where we have at the moment, we have a number of pilots where we do hospital at home type stuff, where we're communicating vital information and clinical grade information back to GPs, for example, back into the acute system. Again, that can be done with home carers. Yeah, so we have 17,500 home carers in Northern Ireland registered on the NISC database. 17,500. The only bigger working population in NI right now is nurses. Yeah, they have a few more thousand. So that home care workforce, what else can we train it to do? What else can we get it to do within the actual, the overall infrastructure within health and social care? How do we make that work better? And this team, this mass of finite physical resource can do a hell of a lot more than it's doing now, and even indeed right up to hospital at home. So at the moment, we have our carers trained to change oxygen tanks for advanced stoma bag care and things like that. So taking on those tasks makes perfect sense. So yes, people will always need help to get out of bed, to get showered. Yes, all the stuff that carers do right now. But what else can that workforce do? But more importantly, how do we digitally enable them? Yeah, to roll out the kind of wearables that we want, to do the data analytics that we want, and how do we use that information with our carers to understand the escalation protocols and how to support people better to live well for longer. And I think that's the critical aspect here. How do we make that happen? So we move from a kind of a time and task home care model to an outcome-based model with everything from digital social prescribing, to good wearable advice and guidance, to good medication products which actually work and remove this idea of the need for physical medication prompting, for example, and actually do it better. And how do we train our home carers to do that better? It's an untapped resource, and we just need to get bloody better at it, because if we don't do this, our hospitals are full, our primary care is full, and social care is the solution to removing or reducing much of the need and much of the excess capacity that we're having to wade our way through right now. And we've got to get that thinking both in terms of service innovation, but also in terms of product innovation as well, and which products and services work best. Just pop on to the next slide. So how do we do more with home care? I've mentioned some of this already. So for example, we don't really have very many. We have a number of hospital discharge projects which have ring-fenced home care to get people out of hospital, to free up beds and to get more throughput through hospitals. We've maybe 4 or 5 pilots for that in Northern Ireland. Yeah, really interesting stuff. But I guarantee you, we could do with about 20,000 hours of that right now, just to get ready for winter pressures in somewhere as small as Northern Ireland with 1.7 million people. It is tiny, but 20,000 hours of care would solve that hospital discharge product right now. And our rate per hour in terms of home care in NI right now is £20.01. It's a really affordable solution to freeing up those vital hospital beds and getting people to home where they want to be. It's not particularly sexy. It's not that, our processes and our staff are all digitized in terms of where our resources are and things like that. It's simple, straightforward. But what about products like triage, hospital diversion? So older people are presenting to A&E today, tomorrow, right the whole way through winter because they can't get an appointment with their GP. Yeah, they can't get somebody to see them. All they really need is some good home care. Right, it might be an issue with medication, one of the biggest reasons for people presenting at A&E, particularly older people. So how can we get home care to triage people away from A&E who have no need to be there, who then block up and glower up the system? Yeah, a really simple service linked to some really simple technology that's tried and tested. Clinical grade monitoring in the home, we talked about that. We have a great partner in the likes of Phoebus who provides that digital clinical grade information. But again, we've one pilot with about 10 people involved in that. It could be 1,000. And that's the honest truth about it. So how do we diffuse this out? And how do we get commissioners to really understand the value of this within the wider system? Outcome-based care, let our carers make the call in terms of where that finite physical care should go on a daily basis for better outcomes. Digital social prescribing, we've mentioned, we have a number of pilots where the outcomes on that have been 25 to 40% better than just regular home care with a really good digital social prescription. Really, really clever stuff. We also need to start gathering the data earlier. Yeah, so using the data to inform where we're going next is critically important. And we got to use our finite physical care better because it's going to get tougher. All our developed nations are getting older faster, and the amount of younger people within this industry is becoming more and more difficult. I will tell you one stat though. We changed the entire recruitment model within our particular business. When we first acquired it 12 years ago, the average age was 52. Our average age today is 29. We've made this an entry-level profession into health and social care, but we've got to keep that talent and grow it through the system. Just move on to the final slide, I think. So intelligent care, just to give you some idea around this, we've got to think about preventative care strategies, relocate our physical capacity, as I've mentioned, but also using that data-driven piece to understand how we escalate in the right way and how we dovetail and work with other stakeholders within the system just to do this in a much more intelligent and better way, and sharing that information in ways which actually adds value to the patient and the client, who must remain at the center of the process. On our final slide, I think. Yeah, one case study just in terms of this. So the model I mentioned in terms of digital social prescribing, it was an outcome-based innovative service model. We had some really good wearable technology with Paxana, but a 61% reduction in actual physical care across the 20 clients that we looked after. 50% of those discharged clients from this due to rehabilitation, with OTs getting involved, other stakeholders in the system. So 50% of those clients no longer even needed home care after they went through this intensive outcome-based home care model. 100% of clients got their social prescription. 63.8% increase in mood and well-being, as opposed to the placebo group that just got regular home care. That was using the Warwick scale, a well-renowned NHS kind of model there. 87% increase in PALM scores, again, an NHS tracking tool, in terms of mobility, etc. And we had 50% of our clients with no internet access before the scheme, who then got online as well, with all the other benefits that actually brings. So in terms of this case study, in rural Lisburn, in a rural area of Northern Ireland, this bloody process of innovating service delivery, bringing it together with product innovation and really proper products that have been tried and tested, adds significant value to patient outcomes. We just need to do more of it. Moving on to another slide. That's as fast as I can do it, folks. More than happy to take questions. I think I have a total of 20 seconds left, and hopefully that give you a flavour for what I believe are the key issues around innovation and digitisation within social care specifically. Thank you.
Ryan, quick question. Is environmental impact already on your radar?
Yeah, so we've about 110 vehicles in our fleet. Blendon is one particular example. We're now moving to a fully electric fleet, so reducing carbon emissions and things like that. The environmental impact of home care is limited. We don't have a huge amount of physical infrastructure, so buildings and things like that. But it has to be on our radar for sure. And we're always looking for other ways of minimizing, reducing waste, all that kind of great stuff. PPE is a bit of an issue, and we have innovative ways of dealing with that, for example. So environmental impact remains very, very important, and the digitization around how we track that has become much more helpful as well.